Tricia, why don't we go ahead and switch over to get started on our presentation. So again, thank you very much for attending, and we look forward to seeing you at other webinars that we do. Just a little reminder of what AHEC does. As I stated, our main work is in a workforce capacity. There's over 300 AHECs across the country in 46 states this year. We've just had some inclusion, and AHECs do individualized programs to recruit health professionals, expand training to the current professionals to get them into rural and underserved communities, and of course support health professions education for those who are in these communities so they don't always have to leave their practice and go somewhere else for training. That's why we're excited about having these opportunities today. This presentation today is jointly provided to you by the Postgraduate Institute of Medicine and the National AHEC Organization. And we are pleased to say that our speaker and the planners of the event have reported no conflicts of interest. And of course, as Tricia has noted, the funding for the presentation is made possible by the Centers for Disease Control. Today, our presentation on how HPV causes cancer and why it still matters is going to be done by Dr. Peter Angeletti. Dr. Angeletti is an associate professor at the University of Nebraska in Lincoln and the Nebraska Center for Virology. Dr. Angeletti received his bachelor's degree from UCLA, a master's from Illinois State University, and a PhD from the University of Alabama. He's done extensive research in a variety of topics, specifically HPV, and even today we'll be sharing with you some of his current research in Tanzania and Zambia. We had the pleasure for the NAO project of being able to hear Dr. Angeletti at another presentation, and we were very excited to see many of the participants in the room who were very knowledgeable in the topic come away with a much better understanding. We heard nurses talk about how they felt that they were more grounded in the true understanding of what this does and how the cancer is caused and why it takes so long, et cetera. So we were excited when Dr. Angeletti would go on a national format and provide this information to you. So with that, I will turn it over to Dr. Angeletti. He will maybe share a little bit more about his background that I might have missed, but otherwise we'll get started with the presentation. Remember the Q&A pod on the right, left-hand side of your screen. We'll be happy to answer any questions. And at the end, we'll open it for some more additional Q&A. So with that, Dr. Angeletti, we'll turn it over to you.
Thank you so much, Gretchen. I really need to thank Gretchen and Tricia for setting this up, and also the national and local AHEC. And I don't know about you guys, but to me, AHEC really stands for a heck of a lot of work. I mean, I'm pretty impressed with what you guys are doing. So as Gretchen mentioned, my background is in HPV research. And so I really come at this with, with the researcher's, frame of mind. I really want to understand the virus, and I want to understand how it causes cancer. And so I think you'll notice that. I mean, as we go through, I'm going to teach you a little bit about the biology of the virus, and we'll try to understand what the virus is all about. And then I will go into some examples to explain the title, and that is, why HPV still matters. I mean, there's a feeling, and especially in the research community, that we've got a vaccine. This work is done. And I would say far from it. There's a lot more work to be done, and one of the most important pieces of work is to get the vaccination levels up in this country, right? So that's really important. All right, so let's get started. Okay, so and again, the objectives are to have everybody understand the importance of the HPV vaccine. And I'll describe how HPV replicates. I will talk about the manifestations of HPV-related disease and dysplasia, and we'll have some recommendations with regard to vaccination for girls and boys. HPV is a virus that is very ancient, okay? So it has been with mammals for 250 million years. And so there are surprisingly 200 different types of HPV. Most people are not aware of that fact. And there's a lifetime risk for coming in contact or getting infected by HPV of about 80%, okay? And there's some variation with that estimate, 50 to 80%, depending upon the literature, but it's very high, we know that. After years and years of research, we now know there's about a 99% correlation between HPV and cervical cancer. And that is the culmination of a lot of years of work showing that both on the molecular side and also on the clinical and epidemiology side that HPV is a causal factor in cervical cancer. Okay, so when we talk about HPVs that cause cervical cancer, we're really talking about the subset of HPVs in the mucosa. Okay, that's to be differentiated from those in the cutaneous, that is skin, dry skin, right? The dry skin warts that we know of, right? Those are the kinds of HPVs that, in general, we don't think of them as causing cancer, okay? So the ones in the mucosa are the ones we worry about, and more specifically, the ones that we would call high risk. And those are ones which, the genotypes in which there's clearly an association with development of toward cancer. And just for example, HPV 16, 18, 31, those are the so-called most important high-risk types. And then the low-risk types, HPV 6 and 11, those are the kinds that make the condylomas, the large warts, right? And so those are the ones that they are also included in the HPV vaccine for that reason. Okay, like I said, depending on the analysis methods, the lifetime risk for contact with HPV is 50 to 80%. There's an estimated 6.2 million people infected every year, and one estimate of the prevalence of current HPV infection is greater than 20 million. Okay. And now looking at some more recent data, and this is some work that was from the CDC, and some of the more recent data using, better PCR techniques has shown the prevalence of HPVs in adults between 18 and 69 somewhere between 40 to 60%, which is really very high, right? And the earlier estimates were quite a bit lower than that, and this, again, I think relates to the improvement in the techniques used to detect the HPVs. So what we're seeing here is a virus which is very thoroughly spread throughout the population, okay? And so when you think about a virus like this, you have to understand that for a vaccine to be effective, you really need to vaccinate more than 80% of the people. That's really going to be the situation with a virus that's so prevalent. Okay. Now, and like we said, we kind of prioritize HPV. We're concerned about the so-called high-risk types, and the ones which are very closely associated with the development of cancer, 16 and 18. And so that's shown here in this. Let me see if I can get the pointer. There we go. So that's shown here. We have prevalence of HPVs in cervical cancers, and of course 16 makes up most of those, and then followed by 18. So this, of course, is the rationale for using both of those in the first version of the vaccine, the Gardasil vaccine, 16 and 18, and then 6 and 11 on the low-risk side. Okay, but just keep in mind that, in fact, we believe that there are at least 16 high-risk types, okay? So the vaccine doesn't cover all of the types. Even the newer vaccine, which is 9-valent, doesn't include all of the so-called high-risk types, okay? It's very important to realize that, okay? And it's also important to know that cervical cancer is still the second leading cause of death of women, in particularly the places most afflicted are developing countries, right? So we're looking at approximately 500,000 deaths per year due to cervical cancer, okay? All right, so, HPV, we know, we're pretty, well aware now, HPV causes cervical cancer, and yes, it can cause vaginal cancers and vulvar cancers, and we know now that it does indeed cause anal cancers. It causes penile cancers at lower rates too, right? So we thought we understood things at this point, right? But what happened was that we started to realize that HPV has other sites that we didn't appreciate that it could cause cancer, and particularly the oral compartment. Okay, so we realized then that men 40 to 50 years old were at particular risk for oral cancer, and most often these oral cancers are HPV positive, 70% of those. And in fact, the tonsillar cancers are 85% HPV positive. And we've also discovered that 90% of HPV-related oral pharyngeal cancers are due to one particular type, HPV-16. So now you're getting the idea that HPV-16 is the bad guy, both in the genital and now in the oral tract. And, this sort of revelation that the head and neck cancers are at least partially due to HPV kind of, surprised people about 10 to 15 years ago, but now we understand. Now we're starting to really get on board with trying to warn people about that these kinds of cancers can be caused by HPV also. And then just by extrapolation, you can understand that it makes sense that HPV could cause cancers in places like the upper airway and in the nasal cavity. And I'm going to show you some evidence today that HPV is involved with ocular cancers, okay? So we now understand that what we're looking at is a virus that causes cancer in different mucosal sites, the most common of which is the cervix. All right, now risk factors for HPV. It turns out that there are lots of things that can influence the course of an HPV infection and also sort of progression toward cancer. Okay, and so these, of course, are very lifestyle-related things, right? Like chemical carcinogens or tobacco. One of the big ones is tobacco. Hormones like estrogen actually influence HPV replication. Immune suppression like HIV, that influences the course of the disease. And alcohol also can enhance HPV-related pathogenesis. So, and these things all contribute to particular molecular events. So, for example, tobacco smoke enhances expression of the viral gene products. Also, some of these other, chemical carcinogens can damage DNA, which also contributes to the process of tumorigenesis, okay? And then just in general, things like nuclear instability. The whole process of cancer development is a process of, causing damage to the DNA and generating, I would call it like dark evolution. It's dark evolution of cancer cells which have an increased growth rate due to their viral oncogenes. And as I said, one of the big surprises was that cigarette smoke enhances HPV replication and therefore HPV tumorigenesis. So it's these two particular compounds found in cigarette smoke, benzopyrene, and then this other isomer of benzopyrene, which has a slightly different shape with a fjord region here. Those two compounds enhance HPV replication, and like I said, that enhances the probability of progression of HPV toward cancer. Okay, so now it starts to make some sense that when we think about oral cancers and cigarette smoke, we may not only be talking about just the causation of tobacco in tumor development, but also the role of HPV in that. So now that starts to clarify things a bit. So I thought it was really important that we kind of talk a little bit about HPV to sort of demystify the biology of the virus so you can understand what it's all about. So the way I think about HPV is as a mini chromosome, okay? So HPV's little trick is that it tries to pretend like it's part of the cell. It tries to pretend that it's just a little chromosome, okay? And so here we have a picture of the HPV genome, okay? And you can see it's very simple. It's, about 7.9 kb in size, 7,900 base pairs of DNA. And it has just a few open reading frames. It has 8 different open reading frames, okay? And it doesn't even carry its own polymerase with it. It uses the host cell polymerase. So basically what it's doing is it's saying to the cell, don't mind me, I'm just a little chromosome. Go ahead and replicate me, and then pass me on to the daughter cells, okay? And it's sort of a bad trick, if you will. And if we really get right down to the point of this, is that it involves expression of these two gene products, E6 and E7, which take over the cell cycle. These other genes are involved with replication, but they don't have anything to do directly with cancer development, okay? So if we go on to the next slide here, here's our list of gene products. And so if we get right down to the point of it, we have these two products, E6 and E7. E6 binds a protein called E6AP, which functions to degrade a cellular protein called P53. And E7 binds and degrades a cellular protein called RB. And so this is really, when you get down to it, these are the roles that the virus has in dysregulating the cell cycle and beginning the process of cancer. It all happens right here, okay? There are other factors that we think are involved, like E5. We think that may influence EGF receptor, that there could be some sort of coincident activity in that way. Now, I want to give you a good idea of what the virus is doing. What is it all about, okay? Now, as I told you, this virus, it is actually what I would call a shy virus. It just wants to get in to the cell and pretend like it's a mini chromosome and not be bothered, okay? The way this works is that the virus wants to gain entry to these mitotically active basal keratinocytes. So any stratified epithelium, any mucosa has these kind of keratinocytes at the bottom layer here. Well, the virus gains entry through a site of wounding, microabrasion. That could happen, all the time, right? That's easily can happen in the oral tract by, by damage as you're eating or anything. And then, and of course, that can happen in the genital tract as well. So now the virus gets in, and it uncoats in these basal layer keratinocytes and releases its circular DNA genome. And then it expresses its proteins that take over the cell, okay? So now this is kind of like, it's kind of like if you have a car, and instead of just a regular street car, you're now going to make this car into a hot rod, okay? And so now what you've done is you've put on the accelerator, and you make these cells grow faster. when they normally wouldn't want to grow fast. When you express E6 and E7, it's kind of like putting the accelerator on and taking off the brake. And so now the cells are growing out of control, okay? And so the virus is doing this for one reason, and that is to make more virus, right? It's to make the cell into a virus factory. And believe me, the whole intention of HPV has nothing to do with making cancer. That's a side effect. But the virus is reprogramming the cells to amplify the cell so that it can make some virus. That's it, right? As a result of all this cellular expansion, you start to get what we would call a benign hyperplasia, or something that we would call like a wart, right? And the other thing that's going to happen in a normal HPV infection is that you're going to get eventually in the uppermost layers of this stratified epithelium, you're going to get production of virus, okay? And so all of that is a normal process for the virus. None of this is abnormal. The abnormal part comes when the virus, when a mistake happens and the virus becomes integrated, okay? And so now let's talk about that part. So everything I just showed you is a normal viral life cycle, but when there's a mutation in the viral DNA, or the DNA gets broken, it can then become integrated into those keratinocytes. It becomes integrated as a DNA copy. And now what that does is instead of having a little circle of a DNA, now you have a linear piece that's part of the cellular genome, and it causes way too much expression of E6 and E7. Okay, so now we've got way too much E6 and E7 being expressed, and then these cells now go through a crazy, I would say, dark evolution in which they go through several genomic changes and accumulate additional mutations. And above all, here's what happens with them, is they are reprogrammed to have no shutoff point. In other words, they will grow forever, right? That's the whole point of immortalization, is that the cells continue to grow forever. And so, of course, this is the problem. And the other thing we know about how HPV causes cancer is that it seems to reliably involve breaking the viral genome in half. And it usually breaks right there and around the E2 open reading frame. So we get a broken viral genome, it gets integrated into the host DNA, and you get high levels of expression of E6 and E7, shown right here. And you can notice here on this diagram here, we have mention of some of these cell lines that we've been studying for years and years. And these cell lines are cancer cell lines, which have integrated copies of HPV. So we know all the molecular evidence is correct. Integration is a major part of the process of tumorigenesis for HPV. Okay, so I mentioned before the whole thing about taking over the cell cycle, and this is probably a bit more detail than you need to know, but just to give you the idea here, I mentioned E6 and E7, and here's E6, and again, the virus is basically trying to take over the cell, and it will bind and degrade P53, and as you may recall, P53's role is in keeping the cell from causing DNA damage, okay? But the virus, of course, doesn't care about that. The virus only cares about making more virus. So once you take off, it's like taking the brakes off, you know, and then the cell will replicate out of control. But viruses don't care about that. They don't care about those mistakes. Here's the other thing that happens, is that E7 does something, and its role is to bind and degrade RB. And so RB's role is normally in silencing this protein called E2F. Now the bottom line with that is, by degrading RB, the cell is then basically expresses all the genes necessary for replication, okay? So this is, again, like taking the putting the accelerator all the way down. And P53 is like taking the brake off. This one's the accelerator. So that's kind of the way that works. Now, if you do those things and you cause HPV integration, you can see the cellular effects, okay? And here, this is what's shown here. So we have an overview of our pathology. And if we're talking about Pap smears, we would call this normal for interepithelial neoplasia. And so this is a very normal epithelial lining, and you can see that it's rather thin, okay? And maybe 20 cells thick, and we have a nice smooth basal layer of keratinocytes. And then the low-grade squamous interepithelial lesion, we now have an irregular basal border here. You see marked thickening of the cell layers. And then in the so-called high-grade squamous interepithelial lesions, we now have a really pronounced irregularity of that basal layer of keratinocytes and marked thickening of that epithelial lining. So now the cells are really growing out of control. And then finally, squamous cell carcinoma. And now what's happening here is the cells are just growing over each other. There's no regulation of cell growth anymore, and there's also necrosis going on in those particular cells. Okay, and so what we know from understanding, looking at the biology of the virus in the site that matters, where it causes cervical cancer, we know that happens in a particular zone of the cervix called the transformation zone, okay? And so these are keratinocytes that occur between these columnar endocervical cells and the ectocervix, okay? And so it's statistically much higher likelihood to find transformed keratinocytes in this transformation zone than anywhere else in the vaginal canal, okay? So that's kind of the way that works. So when a doc does a PAP, those are the cells of interest to look at to see whether they are abnormal. And so here we have just an idea, an image showing what the cervix looks like with the various potential views that you would see for abnormality: low-grade squamous interepithelial lesion, high-grade, and cancer. And so if you really break it down and you really look at the Pap smear, what's happening is you see a marked increase in the size of the nuclei. So that's the feature that we notice, that the pathologist will notice, is a giant nucleus. And then you'll notice weird things like grooving of the nucleus, or irregular nuclear borders. And so just to give you an example, this other keratinocyte on the outside here is a normal late-stage keratinocyte with a tiny petite nucleus, so that looks nice. But these other ones are wrong, particularly because they have very little cyto. Okay, those are the kind of things that we look at when we're looking at PAPs. All right, so that's these are unusual features, right? And so what I wanted to do is from here, we talked a little bit about the kind of typical stuff that we know about HPV, but now we're going to kind of delve into some new things that we found. And so now I wanted to, by talking about some of the work that we're doing in Tanzania, I want to also touch on some of this new information that we're getting about HPV. Okay, so this is work that's funded by National Cancer Institute through a U54 grant, and involves researchers on UNL campuses and also at UNMC. And so what we're doing there is we're doing a cervical cancer screening study of about 1,400 women. The amazing thing is we were able to set up a laboratory over there, train people at this institute, which is called the Ocean Road Cancer Institute. And it's just amazing to be able to have the opportunity to do this kind of work. And the other most exciting thing to me about it is that, There are so many women there that just they are so happy that somebody cares enough to come and try to understand more about cervical cancer and try to help them. So that part is just amazingly gratifying. So what we've done is we have developed very simple and low-cost methods for HPV genotyping. So we're using very standard techniques otherwise. We're doing a typical pap smear analysis, right? We're doing pap smears and we're looking at the pathology of the cells. And then again, we have this method where we can rapidly determine HPV genotypes. Okay, so that's kind of what we're embarked on there. So, and here's just an example of some of the PAPs that we've done, and you can see the abnormal looking nuclei there. So these are kind of rather typical of what we're seeing. And then here's an example of what the kind of data that we're getting in which we see patients who have HPV, and this is our HPV genotyping result, okay? And so this allows me to then talk a little bit about, sort of dispel some of the ideas about HPV. There's a tendency to think that we are either infected with one or another HPV. But that is not the case. Often we see patients that have many different HPVs. So here's one patient that has 1, 2, 3, 4 different HPVs, okay? HPV 11, 30, 18, and looks like 59. And there's 2 others here that have HPV 30. So that's an important feature because it could be that those different viral genomes interact with each other. It could have an influence on pathology. These are things that we want to understand as researchers. So this is, again, something that we care about and we are looking at as scientists. And then we noticed things like of course, there are things that really influence the pathology and influence the numbers of HPVs. And so one of the things that we found was that HIV status has a dramatic influence on the distribution of HPVs. And so you can just look at this graphic here, and you can see that we have in the upper right quadrant here, we have a lot of patients who are negative. But when we look then at the next slide, we see patients who are HIV positive, and you see now the number of patients who are HPV negative is now shrunken, and we have more people infected with HPV, plus they are also of multiple different HPV types. So HIV seems to influence the multiplicity of HPV infection, and by the way, these are all high-risk HPVs here, okay? So we all know that HIV makes things worse. Well, one of the ways it probably makes things worse here is people are infected with multiple different high-risk HPVs, okay? So this is the kind of stuff that we're learning by doing that work. And then here's a kind of a more simplified look, and this simply shows that if we look either at HIV negative patients or HIV positive, you're much more likely to have multiple HPVs if you're HIV positive. And so that's shown here that we could have up to 5 different HPVs in a single person if they have HIV, okay? So we notice these unusual effects as a function of HIV. Okay, and now I just briefly, I'm going to tell you about another part of this, another study that we're doing in Zambia. And this is called ZAMDAP. And what we're doing there is, this is one project in a 2-project study. And what we're doing is looking at the role of HPV in ocular cancer. And you see, this gives you an idea of how many people it takes to do this kind of work. It's really something impressive. And so the story is that we had heard that in sub-Saharan Africa, there are high levels of ocular cancer. And it turns out that that accounts for about 6.3 of all cancers in Zambia. That is the ocular cancers. I mean, and so that's a high number. So we wanted to understand what was going on there. So our plan was then to recruit 438 cases of these ocular squamous surface neoplasias and then start to test them for HPV. And just to give you an idea, when you start to look at the anatomy of the eye, you start to discover that it looks an awful lot like a regular epithelial lining. And it starts to then make some sense why HPV would prefer to infect this. So it's a stratified epithelium, and it also has a region which is providing basically stem cells for the epithelial lining, and those are in these areas called the palisades of Vaught here. Okay, so it has all the look of what you would call like a stratified epithelium in like a cervix. Okay, that's really the structure of it is very similar, I would say. All right, so now and these are just the first couple of patients that we recruited, and here you see clearly enough these are patients with dysplasia on the eye. So, and this looks an awful lot like a wart, right? And then here's patient number 5. And so again, we see, again, growth on the eye, and it seems rather like it's clear and glassy. And then if we look at these patients were treated by the doctors and they removed the lesion. And if we look at the pathology of that lesion, we see the same kind of pathology that you would see in a pap smear. We see abnormally large nuclei, okay? We also see these nuclear halos, which is consistent with coilocytosis, okay? So amazingly, we're seeing exactly what you might see in an abnormal pap smear. And if we take those samples and then we run them through our rapid HPV test method, we find, yep, they are indeed HPV positive, HPV 58, which is a high-risk HPV. Say both of those are HPV 58 positive. And it turns out that all the other samples are HPV positive, but their genotypes were not identified by this test. In other words, they're another type that we don't know yet, and we're going to figure out what those are. And then the other thing that we were not too surprised by is that these patients are also HIV positive, because HIV is a big cofactor for the presence of this OSSN that we're seeing. So that's the little bit of results that that we have from that study. And then that brings me back to the question, why then should we still be concerned about HPV? We have the vaccine. Well, what I showed you reminds us that we're not nearly done with this virus, okay? I mean, I showed you the data that says that about 50% of Americans already have HPV, okay? We know that it's terrible for cervical cancer, right? We now know that it causes oral cancers. And now I'm showing you some evidence that it causes ocular cancers. So yes, we're trying to improve our vaccination. It's so important that we do that. I mean, and now we have more reasons to care about it, I think. And so now I want to turn to the vaccine. I showed you evidence of how bad HPV can be. Now I want to talk to you about, the vaccine, okay? So this vaccine, the first one that we are all pretty familiar with is the Merck quadrivalent vaccine, Gardasil, and that's the 4 different types of HPV, 6, 11, 16, and 18, okay? And that vaccine is made by producing virus-like particles, or VLPs, in yeast, okay? So that's a very clever way of making the virus-like particles. And so that vaccine has been out for many years now. I can't even remember when we started. I think maybe it was 2006-ish, around there. And it's been very successful. And as I think most of you might be aware, there's now the non-valent version of the vaccine out, 6, 11, 16, 18, 31, 33, 45, 52, and 58. And you notice that some of those are those genotypes were ones that we saw in Zambia and also in Tanzania too. Okay. Um, the newest changes I think are that they're going to a 2-dose schedule for vaccination. If the patients are vaccinated before their 15th birthday, if they're after their 15th birthday, the schedule has 3 doses, and I guess the minimal thing is the interval between the doses 1 and 2 is 5 months. Okay. So the main point though is that they need to get those doses in before the patient gets a little bit too older. Now, so here's one thing I wanted to point out about the vaccine efficacy is we have some data from the Australian vaccination. And the Australians had done a really nice job of vaccinating their population. And my understanding from looking at the data was that approximately or close to 80% of young people are vaccinated in Australia, which is extraordinary. And what they're seeing now is they're actually seeing evidence of improvement in levels of genital warts, okay? And so here's on the graph you see females and males, and we're going from 2004 to 2011. And you can actually see now a reduction in the percentage of individuals with genital warts being accumulated over time after vaccination, which is really an extraordinary result, and again points to the fact that this does work, particularly if vaccination levels are high enough. And so then also there people always have questions about the safety, and as we all know, people often have questions about whether vaccines in general are safe. There have been a lot of questions about questions like, can HPV vaccines damage a woman's ovaries? And there's no proof that HPV vaccination causes reproductive problems in women, including premature ovarian failure. And there, I'm sure we've all heard of some of these different questions that people have about vaccines. Is there a role for the vaccine in Guillain-Barré syndrome? And the CDC has not identified any cases of Guillain-Barré syndrome associated with the HPV vaccines. Okay. And what about tachycardia syndrome? And again, here, there's no evidence of this. There's no statistically sound evidence for that either. Okay. So I think that, I think that we all understand that the public has questions and concerns about vaccines in general, but particularly with the HPV vaccine, there's literally no good evidence that there's anything untoward happening with the vaccination. And here now is yet another good piece of evidence showing that in the United States that we have reductions in the prevalence of certain HPVs as a function of post-vaccination. Okay, so here's our look at the reduction in the HPVs in the quadrivalent vaccine. And so here you can see 64% reduction in the 14 to 19-year age group. And in the 20 to 24-year age group, we have about a 34% decline in those HPVs. So again, once again, this says that this vaccination is working, and it's pretty exciting to see this kind of data, especially for somebody like me, that I've been in this field long enough, and wow, we have some very exciting results there. And I think most of the clinicians will be quite aware that CDC recommends routine vaccination at age 11 or 12 and the vaccinations can be started at even as low as 9 years of age. As I mentioned, there are 2 doses for the vaccine recommended, and the second dose of the vaccine should be administered 6 to 12 months after the first dose. So the bottom line with the HPV vaccine is it is most certainly safe, okay? And the evidence is, I mean, I'm astounded at it. It works. It works very well. And the other good evidence coming from years of looking at the original vaccine data is that it's a durable vaccination. It lasts a long time. Okay, so that's really pleasing to see too. Okay, so just my final conclusions here. I've shown you, I hope I showed you some new information about HPV that you didn't know before, that there are 200 different types. That one of the things about HPV is it likes to hide out in people, right? And it can hide out for decades. And I've also shown you some evidence that it is a broad risk for cancers in different sites in the mucosa, okay? So we think it's a key contributor to oral cancers as well as cervical cancer. We think it's involved with ocular cancers. I've also shown you some of the data indicating that HPV vaccine is safe and it works well. And really, to make this succeed in the U.S., we need to get 80% coverage. We're not there yet. We've got a ways to go, but I think that's a good challenge. We should be as good as the Australians on that, I think. And so that is everything I had to present, and I'll take any questions at this point.
Great. Thank you, Dr. Angeletti. Very interesting information, and I think it'll open eyes for folks to see, like you said, the complexity of this and the fact that, it can be all over the place. We do have a couple questions. The first one was back at the beginning of your presentation when you talked a little bit about HPV and the skin. So does HPV have an impact on skin cancer? And if so, how?
It's a great question. I didn't want to go too much into that. I mean, there are some studies that suggest that some of the strains of cutaneous HPV could have a role in skin cancer, particularly HPV-5. But I think that it's still an open question at this point, right? It's not nearly as clear a role as we see with HPV-16 and cervical cancer.
Okay. Another question, of all those who are infected, how many or what percentage generally will turn into cancer?
It's a great question. So it's less than, really, so few people actually ever even show signs of it, okay? Less than 1% of people actually show signs of any infection. And I don't know how many of those will actually progress. The numbers are so low. And the big thing, as you recall with the risk slide, okay, it's all about lifestyle, okay? It's about, and it's the simple things like smoking, drinking, do you get enough rest? Are you, sleep well at night and take your vitamins? Don't stay out too late. It's the simple stuff, right?
Great. Next question. Does HPV lie dormant in the body? For example, if a patient has positive HPV on a PAP on a year and then negative, and then it turns positive again, are things like that happening?
So it's a great question. And I have studied the persistence question, and I believe that HPV it can persist for a long time. Yes. And it all depends upon the strength of your immune system. Over time, it can be it can dissipate, and that involves your immune system kind of blocking HPV into a corner with the immune cells like CTLs blocking it into a corner. Again, I think the longer you go without either getting HPV transmission going on or exacerbating a pre-existing HPV infection, the better off you are. So I actually think that it can be cleared, but it takes a lot of time, is the answer.
Okay. Next question is on the Tanzania findings that HPV seems to be influenced by the multiplicity of HPV types.
Yeah.
So does the HIV infection explain the difference between groups above and beyond the individual level exposure-related risk?
Yeah, right. So, I mean, when you have individuals who are, and in some of these countries we have high levels of HIV infection. So in Tanzania, it's around 5 to 6%, although in the groups the cohort that we're working in, the average is around 12% HIV positive. So here's the deal, is that if people are HIV positive, they are producing more HPV. And so it's kind of, you could think about it kind of like it's kind of like a well of different viruses. So they can transmit more. And in fact, we see the same kind of thing has been shown with Kaposi sarcoma. So KS, the spread of KS, Kaposi sarcoma virus, KSHV, is a lot higher. And there are more people shedding that virus because there are more people who are immunocompromised because of HIV. So it's probably quite similar with HPV.
Okay, next question is related to, is it contraindicated? Is HPV contraindicated in acute infections? Do you know anything about, if somebody does?
Oh, you're talking about vaccination, whether one, I don't think that it would be contraindicated. What I mean by that is, normally when the patient goes in, they go in for the vaccination, they're going to be 9 through 12 years old generally, that you wouldn't have that question anyway, but I know that there are older individuals that get vaccinated even up to like 26 or even older. I think most docs wouldn't even ask the question about whether you're already positive or not,
Very good. We have quite a few questions that are related to the specificity of the current recommendation for the vaccine being given at 11 and 12, and can older people get those vaccines? And those, most of that comes from the ACIP, who makes the recommendations and requirements for vaccines. We will be sure to get those questions specifically to CDC for you versus Dr. Angeletti, and we'll get those answers back to you folks who had those. But there are some others in here, so I'll go through those and check. If a patient has HPV-related cancer, are they then at a higher risk for other mucosal skin-related tissue cancers?
I don't think so. I mean, if you have one, it doesn't mean that you're more susceptible for another. I certainly don't think that that's the case at all.
Okay. Then we have a question about the HPV infection itself. So a person has had some patients who've come back HPV positive on a PAP. Both they and their partners have stated that they have not had other previous partners.
Right.
How can people also get infected?
So I mean, first off, it's more likely that maybe they just already had those viruses, and they've had them for years, and that either they're reactivated, they persist for a long time, and so it's probably more likely that that's the case. And this is also very touchy, of course, relationships and all that, and that's a very difficult thing. But I think that these are viruses that persist at very low level. I mean, like I said, here's what's crazy about it to me, okay? Because I do all this DNA testing. We have had some cohorts in which the HPV prevalence was around 80%. I mean, just imagine that. It was 85% in one of them. So the point being, and then I showed you the study from the CDC that about close to 50% of people are DNA positive for one or another. That just goes to show how common they are. They're just hanging around, and maybe they're at very low level, and maybe it's not until they get transmitted to another person that they start to cause trouble.
And they also can be transmitted through a non-sexual.
Exactly, and that, I didn't talk about that, but this virus, it's a little bit odd because the virion becomes more stable when it gets into the air. It actually requires oxidation in order to become infectious, and it actually becomes more stable, and it can last for years in an inanimate, surface, like on a table, whatever. So the point is that, yes, I agree, it can remain infectious. And that's just straight virology from my point of view. Okay.
Very good. Great. Thank you. Well, we have, like I said, a ton of other questions related to the recommendations for vaccination and those things. And in spirit of our time, we do want to just remind you about the credits and, of course, our next webinar. We will send out those responses to those folks to be sure that we've hit on it. But Dr. Angelotti, thank you so much for a wonderful presentation. And I think the fact that you really honed down into the science of this and made all of us understand a little bit more, back to some of our coursework that we took in college, to really understand how this vaccine works, has been fascinating. So thank you very, very much. We really appreciate your presentation today.
Thank you very much.
Just a reminder to folks, Tricia will leave this screen open for you so that you're able to click on the link to directly go and get your CME or CE